Well, relapsed refractory ALL have a very bad prognosis. So even patients that relapse, especially for patients that relapse after allogeneic stem cell transplant, or even for CAR T-cell therapy. So there are very few studies that have looked into the efficacy of second procedures, so second allo or second CAR T-cells. And for instance of this work, we were focusing on the outcomes of second CAR T-cells. So there are very few studies and almost no efficacy with second infusions. So we were wondering if what we could do, because we believe that this is usually because of a possible role of immune-mediated rejection of the CAR T cells. CAR T cells don't tend to expand or to persist after second procedures. So what we started to do is to giving second CAR T-cell infusions for patients with relapsed refractory ALL that relapsed to a first CAR, and we made adapted procedure. We were giving the conventional fludarabine plus cyclophosphamide conditioning, but we are adding rituximab to the conditioning, and then we're giving more cell dose. So we're not giving just the regular 1 million CAR T-cells per kilo, but we're giving 3 million CAR T-cells per kilo. After this, we have treated 12 patients, and we were a little bit surprised because we saw a complete response rate MRD negative, complete response rate also PET-CT negative, complete response rate of almost 70% with second infusions. Even when the CAR T-cell expansion and persistence and the PFS of second infusions seem to be a little bit lower than the first one, we could be able to identify that around 50% of responders, the second infusion, the second treatment, we could achieve better outcomes. So there are patients that are still on ongoing remission, some of them more than 3 years. So we believe that with this adapted procedure, we are able to salvage and potentially cure at least a half of patients that respond to second CAR T-cell infusions.